Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is Introduction to Dolutegravir-based regimens and Phase 1 Transition Plan. And the speaker is Dr. Priya Patil. Dr. Priya Patil is currently working as Deputy Director, COE JJ Hospital and alternate nodal officer for both ART centers at JJ Hospital. She is an Associate Professor of Medicine in Grand Government Medical College and Sir JJ Group of Hospitals, Paikala, Mumbai. She has done her MBBS and MD from BJMC Pune. She has done many theses and studies on HIV, out of which one is published. She has done study at ICMR on OI profile in HIV. We welcome you, ma'am, for today's session. Ma'am, you are requested to please unmute your mic.
Good afternoon, everybody. Before I start my RDLS session for today, I really appreciate all the ART staff members who are in this COVID pandemic. They are coming and giving good patient care, because of which our PLHIV are able to get proper ART. So I am very thankful and grateful for all the ART staff members who have been coming in this pandemic and giving good patient care to our patients. So now we begin with the introduction to dolutegravir-based regimens and the transition plan. So the objective of this session is we want to introduce to DTG. Now this is, as you all know, dolutegravir is now going to be introduced into the National AIDS Control Program. So we are going to discuss about what is the rationale of dolutegravir use. Then we are going to discuss some amount of pharmacology of dolutegravir and benefits of DTG. Then dolutegravir-based regimens in first, second, and third line ART. Then DTG in special situations like HIV, TB co-infections and women in reproductive age group. Then we also want to discuss about dolutegravir-based ART as post-exposure prophylaxis, what is its role and how it is more effective. And then we will be discussing the main thing, the phase 1 of NACO's DTG transition plan. So coming to why dolutegravir-based regimens, now why we are slowly going to change all our regimens to dolutegravir regimen. Now, dolutegravir achieves a very fast viral suppression sooner than efavirenz-based regimens. So, because of this rapid viral suppression, dolutegravir is much more effective. The action is much faster, and so it reduces the transmission also. So the viral suppression by dolutegravir, it occurs at less than 50 copies per ml, occurs at 4 weeks as compared to 12 weeks for efavirenz. Then there are many the toxicities and side effect profile of dolutegravir is much better than efavirenz. As we all know, with TLE as the first line regimen, there were a lot of discontinuations because of efavirenz neurotoxicity. However, there are single discontinuations with dolutegravir less than 2%, which is much less with as compared with efavirenz. Again, rash, the incidence of rash with dolutegravir is much less, 2% versus 13%. And the neuropsychiatric events, because of which lot of discontinuation happens with efavirenz, which includes dizziness. It were significantly more common with efavirenz, 35% with efavirenz as compared to 5% with dolutegravir. So as we can see, the side effect profile is much better with dolutegravir, so it is much more tolerable, and so patients are going to tolerate it well. So the compliance is going to be much better with dolutegravir. Now there is a slightly more incidence of insomnia, which is more frequent in DTG, 13% versus 7% as documented in the single study. But apart from this increase in insomnia, the other side effects are much more with efavirenz as compared to dolutegravir. Again, dolutegravir is a much more potent regimen. There is no known treatment emergent resistance across all the studies which have been done so far. Again, if we see the drug interactions with dolutegravir, there are minimal drug interactions. Only thing, there is one significant interaction along with rifampicin. Because of rifampicin enzyme induction, the levels of dolutegravir are reduced, and that's why we have to currently it is recommended to increase the dose of dolutegravir to 50 milligram BD from OD whenever there is TB co-infection and treatment with rifampicin. So that we are going to discuss again and again. It is going to come in the further slides also. Then there is a high genetic barrier. We are going to see that. So it is very difficult. It is dolutegravir. It is difficult for the virus to develop resistance. So that is the high genetic barrier. Again, it is effective against HIV-2. So the same regimen will be common to HIV-1 as well as HIV-2. So it is the ease of a single regimen working across all the treatment groups and harmonization across patient population. So all these are the different advantages, and that is why dolutegravir is being introduced. Now coming to the rapid and sustained efficacy of dolutegravir. The single study which included ART-naive patients, 833 patients, it was demonstrated that dolutegravir with abacavir lamivudine, this regimen, it was statistically superior versus the PEE regimen. So that we are going to see in the graph, 88% versus 81% remained undetectable at 48 weeks as compared from the dolutegravir compared to the PEE group, and 80% versus 70%, 72% remained undetectable at 96 weeks, both of which were statistically significant results. Again, there is a faster viral suppression as compared to efavirenz, in average of 4 weeks for dolutegravir compared to 12 weeks for efavirenz. So you can see in this graph that when we compare this lower graph shows the regimen of PEE versus upper graph shows the regimen of abacavir lamivudine DTG, and you can see that 88% versus 81%. So at 48 weeks, so it was superior to the PE regimen, and again this same efficacy continues at 96 as well. So 80% compared to 72%, which achieved the viral suppression. Again, if you see this, there is a faster viral suppression at 8 weeks. 4 weeks for if you see this 4 weeks, this viral suppression is much higher in the dolutegravir group as compared to what is achieved. The same result is achieved in almost 8 weeks for the PE group. So a faster viral suppression and a robust viral suppression as compared to efavirenz group. Again, along with this, dolutegravir is generally well tolerated. Again, in this single study, it was shown that it was better tolerated versus the PE regimen with fewer discontinuations, because there are much more discontinuations in the efavirenz group because of the neurotoxicity profile of efavirenz. So 2% versus 10% discontinued due to adverse effects at 48 weeks. So 2% in the dolutegravir group, whereas PE group there were 10% discontinuations. Similarly, 3% versus 11% discontinued due to adverse effects at 96 weeks. So much lesser discontinuations with dolutegravir as compared to the efavirenz group. Now, again, there have been different studies. I am not going to go in detail of all these studies. The single study, spring study, then there was a flamingo study and sailing studies. Now, all these studies showed that there were fewer resistant mutations with dolutegravir than raltegravir. So, dolutegravir was superior to raltegravir in the sailing study. The superiority over raltegravir was established. Again, in the flamingo study, there was no emergent integrase inhibitor mutations through 48 weeks with dolutegravir. So definitely there was a high barrier of resistance. So this slide shows the potency as compared to the barrier of resistance. So in the extreme right corner, we can see there are these drugs, darunavir combined with ritonavir or cobicistat, then dolutegravir. So these two drugs we can see which are being used in the program currently. So they are having advantage of highly potent as well as a very high barrier to resistance. Then there are some drugs which you can see on this side. So they have potency, so like tenofovir and lamivudine, TE, etc. So they are potent, they are low potency and again low barrier to resistance. Then there are some like raltegravir, the potency is much better, but barrier to resistance is lower. So much lower as compared to darunavir. So the drug which has both potency, advantage of good potency as well as high barrier of resistance, these are the best drugs. So dolutegravir has both these advantages of being highly potent as well as a high barrier to resistance. Now coming to the issue of dolutegravir in pregnant women. Now there is an ongoing trial in Botswana. Now Tsepan takes place at 8 of the largest maternity wards in Botswana. So here 45% of the total births account in the country. And in the early analysis done at this site in 2018, they identified 4 neural tube defects out of 426 women taking dolutegravir at the time of conception for a rate of 0.9%. So at that time in the early phase, the incidence of neural tube defect was documented to be 0.9%. However, the updated data shows the prevalence has declined from 0.94%, that is 4 out of 426 exposures, to 0.3%, that is 5 of 1,683 exposures. So the incidence is shown to be much less now. So 0.3% means 3 out of 1,000 births. Now the difference remains statistically significant compared to efavirenz, but the overall risk is quite low. Now women on efavirenz at conception had a neural tube defect risk of 0.05%, whereas the other ARVs had a risk of 0.112%. So the risk with dolutegravir is slightly higher with other ARVs also, that is 0.3%. But if we see the overall other advantages of dolutegravir we just now discussed, then dolutegravir still remains a very good option in pregnant women, and it is safe to initiate DTG based regimen in pregnant women beyond the first trimester. So this is very important thing in the counseling of pregnant females. Now whenever we will be starting to use dolutegravir, that time this counseling will be important, because as per NACO guidelines, the decision will be taken by the pregnant woman, but for that, for her to take a proper decision, we have to do a proper counseling, giving all the pros and cons. So risk versus benefits of dolutegravir used in women of childbearing potential. Now benefits of dolutegravir include greater maternal viral suppression, fewer maternal deaths, fewer sexual transmissions, and fewer mother-to-child transmission of HIV. Now, risk of DTG in women of childbearing pregnant women include adult morbidity resulting from DTG, that is associated weight gain, and neonatal deaths among infants of pregnant women with DTG associated weight gain. So, the risk-benefit model suggests that benefits of DTG for this group is likely to outweigh the risk associated with this. Now, blanket exclusions that deny women equitable access to this optimal HIV treatment with DTG are not warranted or justified. That's why we have to explain women of childbearing potential, the risk versus benefit potential, and then take decision. Now, ELD and adult women and adolescent girls of childbearing age. The guidelines say that effective contraception should be offered to adult women and adolescent girls of childbearing age or potential. DTG can be prescribed for adult women and adolescent girls of childbearing age or potential who wish to become pregnant or who are not otherwise using or accessing consistent and effective contraception if they have been fully informed of the potential increase in the risk of neural tube defects. In case a woman does not want to initiate TLD, after adequate counseling, she should be initiated on TLD. If a woman is identified to be pregnant after the first trimester, DTG should be initiated or continued for the duration of the pregnancy. Coming to the mechanism of action of DTG. So we already, all of you know the different classes of ARV drugs, the nucleoside reverse transcriptase inhibitors like zidovudine, stavudine, lamivudine, abacavir. We have non-nucleoside RTIs like nevirapine and efavirenz. Protease inhibitor in the program are lopinavir, ritonavir, atazanavir, darunavir. And then you have nucleotide reverse transcriptase inhibitors like tenofovir and tenofovir alafenamide. Coming to integrase inhibitors, so dolutegravir is one of the integrase inhibitors. So raltegravir, which is it was being used till now, and now it is going to be replaced by dolutegravir. So it is the integrase stand transfer inhibitor in STEAM. So I'll skip this slide now because all of us know basically what the reverse transcriptase inhibitors, they from the viral RNA, they help in the DNA formation, and then this viral DNA is then integrated into the host cell genome by the integrase inhibitor, and at the step of integrase strand transfer, there is the action of the integrase inhibitors. Dolutegravir will act at this site. Now coming to adverse effects and drug interactions of dolutegravir. So side effects, one of the side effects we already had discussed, that dolutegravir causes insomnia, then there can be headache, dizziness, tiredness, there can be allergic reactions, then there is dolutegravir associated weight gain. So WHO recommends to highlight the importance of a healthy diet and regular exercise to help manage the weight in these patients. Now coming to the important drug interactions with dolutegravir. Amodiaquine is an anti-malarial reagent, so it is not really used right now. So here we don't anticipate much of a problem because it's not being used in the treatment of malaria. Coming to carbamazepine, carbamazepine is used as an anticonvulsant. So whenever it is being used as an anticonvulsant, then we have to use dolutegravir twice daily in such a patient, or we substitute with an alternative anticonvulsant agent. Again, phenytoin and phenobarbital also have the same interaction. They are all enzyme inductions and enzyme inducers, and so we need to use an alternative anticonvulsant agent along with dolutegravir. We cannot use these anticonvulsants. Doptetalide is an antiarrhythmic drug, and again we have to use an alternative antiarrhythmic agent when we are using this, when we want to use dolutegravir. Again, metformin, the serum levels of metformin are increased by dolutegravir. So to avoid adverse effects, it is advisable to limit the daily dose of metformin to 1000 mg when used with dolutegravir and monitor glycemic control. So if the sugars are not controlled with the 1000 mg metformin, then we have to give the other anti-diabetic agents, like we can give leptins, teneligliptin, or we can use glimepiride and other drugs. So this we must remember, because many of our PLHIVs who are diabetics, they are on metformin. So when we are going to use this dolutegravir based regimen on such patients, we have to check the dose of metformin, and many times metformin, commonly many patients are getting 500 mg TDS. So if such a high dose is going, then we have to reduce the dose of that metformin, and then if required, give some other antidiabetics. Again, one more important drug interaction is with commonly used antacids like gelusil and multivitamins and calcium ion supplements. So if we are going to use these calcium ion supplements or multivitamins or tonics along with the dolutegravir, then it is advisable to use these agents 2 hours before or 6 hours after dolutegravir intake. So you cannot take it simultaneously, either 2 hours before or 6 hours after DTG. So that should be remembered, because very commonly this PLHIV, they feel that they are weak and they will be using this over-the-counter products also, or without the knowledge of the ART center also, they may be taking from their local doctors these these drugs. So it is very important at the ART center to inquire whether they are taking such multivitamins or calcium supplementations, and accordingly counsel them that they have to be used either 2 hours before or 6 hours after discharge. Then rifampicin, again and again we are going to stress this, that whenever we are going to use rifampicin as a rifampicin based AKT, then dolutegravir has to be increased, the dose has to be increased to 50 milligram twice daily, or substitute with rifabutin. Now, how dolutegravir is proposed to be used under the national program? So these regimens have to be implemented. Right now it is going to be in stepwise fashion, and as and when there will be office memorandum from NACO about its use, that so the regimens have to be started to be used only after NACO releases these OMs. So for example, for first line, we are not starting with first line now. Whenever NACO releases a memorandum that DTG can be used for first line, then only we have to do that. So right now we are not to do it for first line. It's only for altagrav, which will be coming now. So it is very important that we have to use it as per the stepwise release of office memorandums from NACO, because the stocks have to be arranged accordingly. So we cannot suddenly begin the transition. So right now, where we are going to use, that also will be discussed. So the transition to DTG based regimen phase 1. Now this transition is going to happen only after the official release of the OM. Just now we'll be just discussing the plan. So DTG based regimens for treatment of HIV positive adults, adolescents and children weighing more than 20 kg or age more than 6 years. So that is the plan. Now these regimens will be the preferred regimens in the national program for new PLHIV as well as already on ART PLHIV. Selection of appropriate DTG based regimen would depend on the viral load suppression status of the PLHIV and the current ARV drugs being used. PLHIV on various ARV regimens will be gradually shifted to dolutegravir based regimens in a phased manner. So it's very important that it is going to happen in a phased manner, and so we cannot suddenly shift it to all patients. So the transition plan would be based on the drug stocks availability. NACO would be issuing office orders from time to time for transition to DTG based regimen, and these DTG based regimens to be implemented after release of office memorandum from NACO. So the upcoming guidelines: first line ART regimen in ART naive adults and adolescents. So the preferred first line ART regimen for all PLHIV with age more than 10 years and weight more than 3 kg would be tenofovir 300 mg plus lamivudine 300 plus dolutegravir 50 mg in a single fixed dose combination. So there will be one tablet once daily. It can be taken at bedtime or any fixed time every day as per the patient's convenience. And this regimen will be applicable for HIV-1 patients, HIV-2 patients, HIV-1 and 2, women exposed to single dose nevirapine in the past, and PLHIV co-infected with TB or hepatitis B and C. So this regimen will be applicable to all populations across, including 1, 2, HIV-1 and 2 combinations, etc. Now, women of childbearing age or potential should be provided informed choice about the benefits and risks for the use of dolutegravir. Now, these guidelines will be implemented only after the release of OM from NACO and not now. So, there should be no confusion in this. Please remember that this first line regimen will be implemented not now, will be at a later date when NACO will be issuing us a OM officially to use it for the first line. Again, in the upcoming guidelines, PLHIV with body weight less than 30 kg, the alternate regimen will be abacavir 600 with lamivudine 300 one tablet, AL with DTG 50 milligram once day. So there will be a separate DTG tablet. Now all patients with high serum creatinine values above upper limit of normal. So we'll have to calculate creatinine clearance. The combination will be, the regimen will be abacavir 600 milligram OD, lamivudine, the dose will be as per the creatinine clearance, and DTG will be 50 milligram once daily. There is no change in the dose of dolutegravir in patients with high creatinine values. Then special situations, PLHIV on rifampicin containing ATT regimen. So we are the tablet will be tenofovir, lamivudine, DTG once daily. That is the fixed dose combination which the patient is already in the evening, and additionally there will be a DTG tablet separate of 50 mg in the morning. So DTG will be twice. One DTG tablet will be in the combination, fixed dose combination, and the other DTG 50 milligram dose will be in a separate tablet, either morning or evening as per the patient preference. Then females in reproductive age group who opt out of TLD. So suppose after counseling, a female in a reproductive age does not want to take TLD, then such a female will be on TLE regimen. However, if efavirenz is contraindicated in her, for example, situation like HIV-2 or HIV-1 and 2, or there is a prior NNRT exposure, then in such a case, we have to use TL lopinavir ritonavir in that patient. Now, I just want to show this slide here, but you might get confused. So this is not going to be implemented to slightly later date, but just for your knowledge, what will be the upcoming second line regimens in different situations. So suppose the first line ART was zidovudine containing, failed on NNRT or PI based first line, like for example ZLN, ZLE or ZLLPVR. That was the first line. Then the second line will be TL with dolutegravir. However, if tenofovir is contraindicated, for example, patient has high creatinine, then in that case, abacavir instead of tenofovir. Now, if the first line was tenofovir or abacavir containing, like tenofovir TLE regimen or abacavir lamivudine efavirenz or TLLPVR, PI based first line as well. TLLPVR was the first line. Then the second line regimen will be ZLD, that is ZL zidovudine lamivudine with dolutegravir. But if the HB is less than 9 grams, in that situation, dolutegravir with lopinavir, that will be the alternate regimen. Now, first line ART was supposed TLD. For example, now we will be starting to use TLD in our first line, and then so the patient will, if the patient fails on this INSTI based first line, then the second line regimen for such a patient in future would be ZL plus ATVR. But if the HB is less than 9 grams and we cannot use zidovudine, then dolutegravir BD with lopinavir. So that would be the second line regimen there. Dolutegravir in the BD dose with lopinavir. Now suppose the patient fails on ZLD with INSTI based first line, then the second line regimen here will be TL with atazanavir ritonavir, TL ATVR. If we have a multi-NRTI exposed patient, so here many NRTIs were used in the consecutive fashion, and the patient was on NNRTI based first line. For example, patient was on TLE, then Z also was used, Ravudine was also used, so multiple. So just like we used to take shift this patient on RAL LPVR, now we will be shifting such NRTI exposed patient on dolutegravir with lopinavir ritonavir combination. Again, multi-NRTI exposed with PI based first line, like many NRTIs and also PI based first line, then such a patient will move on to dolutegravir with DRVR as in the second. Now, any PLHIV co-infected with TB receives BD dose of dolutegravir until the patient completes ATT, and then after that OD doses continue. Then PLHIV co-infected with hepatitis B will receive additional TL in the second line regimen along with the whatever change second line regimen. Now, third line ART. Third line regimens should include new drugs with minimal risk of cross resistance to previously used ARVs. So, third line ART will be formed by INSTI and a new boosted PI. The third line ART will be started by ART centers after receiving advice from SACET of the respective select linked ART plus center or center of excellence. SACS in consultation and approval from NACO may authorize the MO or SMO of other ART plus centers based on their functioning or capacity. So the regimen for third line will be dolutegravir 50 mg twice daily with darunavir 600 mg and ritonavir 100 mg twice daily. Now, DTG will be used in OD dose if the drug was never used in the first or second line ART regimen. So, if there was no raltegravir in the second line regimen or dolutegravir was never used in the first or second line regimen, then the third line regimen in such a case can be with dolutegravir OD dose. Any PLHIV co-infected with hepatitis B will receive additional TL in the third line. Now the upcoming guidelines for children. The WHO recommends dolutegravir as the preferred first line drug for all the children in the age more than 6 years. Because of limitations in widespread availability of pediatric formulations in India, so the lower dose dolutegravir, that is 25 mg, is not available. So the pediatric ART technical resource group recommends following regimens based on the age and weight of the children. Now weight less than 20 kg or age below 6 years. That is the first group, age below 6 years or weight less than 20 kg. The recommended regimen will be abacavir, lamivudine with lopinavir ritonavir. Then weight between 20 to 30 kg and age between 6 to 10 years. The recommended regimen will be abacavir, lamivudine and dolutegravir. Whereas weight above 30 kg and age above 10 years, it will be like the adult guideline, that is ELD regimen, tenofovir, lamivudine and dolutegravir. Again, right now we are not going to implement these guidelines in children also. These guidelines will be implemented after release of OM from NACO. So this is the same thing in a tabular flowchart form. So in a child with HIV, confirm HIV infection with virological or serological testing, then treat and stabilize the acute condition, and opportunistic infection must be treated first, then baseline CD4 and other lab investigation, and then depending on the age of the child, if the child is less than 6 years or less than 20 kg, it is abacavir, lamivudine and lopinavir ritonavir, it is AL plus LPBR. Between 6 to 10 years and weight between 20 to 30 kg, the regimen will be abacavir, lamivudine and dolutegravir, that is ALD. However, if the age is more than 10 years and the body weight is more than 30 kg with no renal disease, then the regimen will be TL with dolutegravir. If there is a renal disease, then the regimen will be abacavir, lamivudine, dolutegravir. Again, age more than 10 years but body weight is less than 30 kg, then the patient will receive abacavir, lamivudine, dolutegravir. Now again, upcoming guidelines for ART regimen for children with HIV-TB co-infection. So DTG based ART for TB HIV co-infection on rifampicin based ATT. Children with HIV who is on rifampicin containing ATT regimen should receive an additional dose of dolutegravir every day. So first line pediatric regimen then would become, coming to the weight less than 20 kg, age below 6 year group, the regimen will be abacavir, lamivudine with lopinavir, ritonavir with super boosting of ritonavir. So here super boosted LPR regimen has to be used because we cannot use dolutegravir here. Then weight between 20 to 30 kg and age between 6 to 10 years. Here the regimen will be abacavir, lamivudine, dolutegravir with an additional dose of tablet dolutegravir 50 mg after 12 hours. So in this age group, we have to give an additional dolutegravir dose of 50 mg. And weight above 30 kg and age above 10 years, it will be PLD regimen, lamivudine dolutegravir with an additional dose of dolutegravir 50 mg after 12 hours. Now, upcoming PEP post-exposure prophylaxis guideline. As we saw, dolutegravir has a faster viral suppression. It is much more potent. So, it is also included in the post-exposure prophylaxis regimen of choice. So, the regimen will now be tenofovir 300 mg, lamivudine 300 mg with dolutegravir 50 mg OD. One tablet once daily. So, the recommendation will be within 2 hours of exposure, we have to give one tablet stat, either at daytime or at night time. Whenever the exposure occurs, within 2 hours of that, we have to give one tablet of TLD, and then from next day, one tablet once daily, continue for 4 weeks. Again, this is to be implemented after the office memorandum of NAC. Now, PEP drugs for children. 3-drug regimen given in a dose as per weight band. ZL is recommended as the preferred backbone for HIV PEP for children. ZL is advised if there is HB is less than 9 grams, then abacavir lamivudine is advised in children. Whereas TL can be given in children beyond 10 years and more than 30 kg weight. Third drug option are LPVR or dolutegravir. LPVR for children less than 6 years of age and weight. So ZL plus LPVR, that can be the combination, and DTG can be used for children more than 6 years of age and weight 20 kg. So the third drug can be either LPVR if the age is less than 6 years, or more than 6 years we have to use DTG in the PEP regimen. Now the most important, the phase 1 transition plan. So this is the plan now for the phase 1 which we are going to implement. So in the phase 1, DTG will be initiated in the first phase in following categories. So only these categories now we will be in DTG will be initiated. So all the patients currently on raltegravir based regimens and patients who need to be switched to third line ART or to alternate second line ART. So here DTG will be the preferred integrase inhibitor instead of raltegravir. So currently in this phase 1, it should be clear, all patients currently on raltegravir based regimens, they will be now initiated on dolutegravir instead of raltegravir, and patients who need to be now switched to third line ART or alternate second line ART instead of raltegravir. So these are the two groups where we are now going to shift to dolutegravir currently. So details of the phase 1 of DTG transitions. Now the current regimen is raltegravir with lopinavir, LPVR, suppressed virologically if the viral load is less than 1000 copies per ml or TND. Then the recommended regimen will be LPVR 200 mg, 250 BD, 2 BD with dolutegravir 50 mg OD. However, if the viral load is more than 1000 for a regimen on raltegravir and lopinavir, here it will be like a failure on this regimen. So the patient will have to be shifted to third line completely, that is dolutegravir 50 mg in the BD dose with darunavir 600 mg BD and ritonavir 100 mg BD. So it is very important to do the viral load. If the viral load is suppressed, then the patient will move on to DTG 50 mg OD with lopinavir same dose 2 BD. But for unsuppressed viral load, patient moves on to the complete third line with DTG 50 mg OD BD and DRV 600 milligram BD and ritonavir 100 milligram BD. Now, if the patient is already on third line, that is raltegravir with DRVR, again we do a viral load. Viral load is less than 1000 copies per ml or TND. Then the patient will be on DTG 50 mg OD and DRVR. If the viral load is more than 1000, then patient will be on 50 mg BD of dolutegravir with DRVR. So I think this is very clear to everybody. Now, if the current regimen is multi-NRTI exposed patient with virological failure who need second line initiation. So if a patient is exposed to multiple NRTIs and has virological failure, then generally we give such a patient raltegravir with LPVR regimen. So now in such a patient, we will be giving dolutegravir 50 mg OD with LPVR 250 BD, 2 BD. Now, second line failure patients, that is 2 NRTI plus PIs, who need third line ART. These second line failure patients were never exposed to INSTI. So, in this case, the regimen will be DTG 50 mg OD with DRVR BD. So, already if the patient is on third line, like we saw, patient already on third line, viral load is suppressed, then the DTG is OD. Third line viral load is unsuppressed, we give DTG BD. Now second line failure, who is now going to third line, we give DTG OD, 50 mg OD with DRVR. And even for multiple NRTI exposure patients with failure who need second line, will be DTG 50 mg OD with LPV. Now, if the viral load testing is a challenge, as in the current COVID situation, decision on DTG transition may be based on the latest available viral load result. And again, a CD4 count also will be taken into consideration to see if the patient is responding to this regimen or not. Now, coming to monitoring and follow-up of PLHIV on second line. Body weight for every visit. It is important to monitor the body weight on the dolutegravir based regimen. Treatment adherence we have to do every visit. So whatever we have been monitoring, the same thing. Clinical monitoring for OIs, 4S screening for TB and T staging every visit. If treatment adherence is poor or major OIs identified, steps need to be taken to improve that. Lab evaluation based on ART combinations used, that we have to do every 6 months of symptom directed. CD4 count every 6 months and viral load every 6 months. Now, DTG transition, what are the important points for the ART center? The available stocks of raltegravir shall be utilized first. I think in Mumbai, everywhere the stock is now already utilized. So that's why we can move on to using dolutegravir. DTG and BD dosage for HIV TB patients. Now, PLHIV on rifampicin based ATT, BD dosage is recommended. But here I want to clarify one issue, that all patients now which we are supposed to do the transition, they are on third line, that is they are on raltegravir, darunavir, ritonavir, or on the second line patients, RAL LPVR patients. Now in these group of patients, the TB regimen is always rifabutin based. So in this class of groups, we need not, because they are on rifabutin, we do not have to use DTG BD. I hope this point is very clear to everybody. Right now, we are going to transition of dolutegravir only in the third line or second line failure groups. So in this group, we are using rifabutin based ATT because patients are on PIs. And so in this group, the DTG dosage will be remaining OD only. This is very important. Otherwise, we'll be giving unnecessarily BD dosage in this group of patients. I hope this point is clear to everybody. Now, DTG in OD dosage for children. In case of children on raltegravir based regimen, if a weight of child is more than 20 kg and if age is less, more than 6 years, raltegravir may be replaced with DTG 50 mg OD. Now, viral load testing for DTG transition. I think in Mumbai, as per the feedback given by APD madam, viral load testing, it is being done in most of the patients. It has already been done. So for PLHIV already on ART, viral load test should be done before transition to a new regimen. And patients, so all patients who are on raltegravir now, they must have had a viral load already, and if not, the viral load is being done. Patients should have completed at least 6 months of ART on any ARP regimen. Virally suppressed, all transitions to be done after a single suppressed viral load of less than 1000 copies. And here the dolutegravir dose will be 50 OD in the group which we saw now. Virally unsuppressed, we have viral load more than 1000 patients shall undergo enhanced adherence step-up counseling for 3 months. While continuing the same regimen, the patient should have an adherence of more than 95% for conducting a second viral load test. Now, in the current scenario of lockdown due to COVID-19 pandemic, since viral load testing is a challenge, decision of the current DTG transmission may be based on the latest available viral load result done anytime in the last 6 months, or on the basis of one viral load which is done recently. Now, there is a special note for counselors at all counselors at ART centers. All PLHIVs transition to DTG based regimens to be counseled and informed about the rationale for transitioning to the newer regimen. DTG can be prescribed for adult women and adolescent girls of childbearing age or potential who wish to become pregnant or who are not otherwise using any consistent and effective contraception, if they have been fully informed of the potential increase in the risk of neural tube defects. If a woman is identified to be pregnant after the first trimester, DTG should be initiated or continued for the duration of the pregnancy. Counselors should explain the benefits of DTG, that is greater maternal viral suppression, fewer maternal deaths, fewer sexual transmissions, and fewer mother-to-child transmissions of HIV for all the women of childbearing age that are likely to outweigh the risk associated with it. Capacity building of ARTC staff, training of ARTC SMO would be done through platforms like MDACS, RDLS, telemedicine, etc. in the current lockdown situation. Respective online and classroom sessions of blended clinical training are being modified. One-day training of all other concerned ART staff like care coordinators, counselors, pharmacists, and data managers will be conducted, and online material will be uploaded on NACO website for referral. Printed IEC material is under development for staff. Job aids, ready reckoner for MO on ARV regimen transmission and drug interactions. Flip charts and checklists for counselors will be provided. Patient information sheet for educating PLHIVs on the new DTG regimens are under development. Revised recording and reporting formats will be shared with all SACs or COE and ART centers soon. So with this, we finish our RDLS, and if there are any questions.
Participants having any question, they can unmute themselves and ask the question.
More. If there are no questions, are there any questions?
Madam, there was one question actually when I was interacting with ART centers. Like if suppose a patient is on raltegravir based regimen and his viral load is suppose maybe done in the month of February or March and it is unsuppressed, it is unsuppressed more than 1000. And right now the raltegravir stock is not there, suppose, then how the dose of dolutegravir will be decided, because patient has finished EAC also, and because of lockdown the patient may not be able to come for viral load testing.
Yes, but if the viral load was before initiating raltegravir, it was more than 1000 or how it was? After initiating in the month of, but after how many months? So if it was after 6 months of raltegravir and done in March, so it is the most recent viral load we can take.
Okay.
And if it is unsuppressed, then based on that March viral load, we can give dolutegravir 50 mg BD.
Okay. Okay. Thank you.
There is a question: can we prescribe post-exposure prophylaxis in adult regimen henceforth? No, we are right now only the raltegravir based regimens are going to shift to dolutegravir. All other things we have to prescribe, we have to change only after there is a OM from NACO saying that we can now shift to dolutegravir, because otherwise there will be stock issues. So please make it very clear. Right now the transition phase 1 is only for raltegravir based regimens, and that too preferably with the use of the latest or the recent viral load, and not in any other.
Hello, ma'am. Hello,
Yes.
ma'am.
Yes.
If the patient is HIV2,
Yes.
so a viral load cannot be done. So how we will take the decision according to CD4?
No, but right now HIV2.
Change the raltegravir. If the patient is on raltegravir.
If the patient is on raltegravir, then what we can do is we always take a decision based on CD4. So I think we can see the CD4. If it is CD4 is good, that the patient is what was the baseline CD4 at the time of starting that regimen, raltegravir regimen for that
Raltegravir.
Yeah. And
okay.
if
it is increasing,
then you give 50 mg OD. But however, if the CD4 has fallen, like more fallen than the baseline, then you can give BD.
If it is showing failure according to immunological failure.
Yes.
Then I will give BD.
Yeah.
Okay, ma'am. Thank you so much.
So any other questions? Okay, then if there are no other questions, then we can, I think, end this session. I thank ITech for all their support so that we could take this RDLS today. Thank you.
Thank you, ma'am, for this informative session. Thank you to all the participants for patient listening. Yeah, we can end the session now. Thank you.